Welcome to the 8th Annual Sexual and Reproductive Health Webinar. My name is Craig Tower. I'm the Senior Program Coordinator of the Mid-Atlantic Regional Public Health Training Center. The topic of this year's presentation, as you can see from the screen, is preventing and managing congenital Zika and congenital syphilis infections. Before we begin our presentations, I'd like to invite our online participants to visit our website to view our available online and face-to-face trainings. In addition to finding the archived webinars in this series, you can find more information about our center's trainings and the professional development support we provide to health departments in Maryland, DC, and Delaware. For those watching online, we invite you to email questions for the presenter at any time, and you can see the email address on the screen. I'm going to turn over the microphone to Ken Ruby, Chief of the Center of Sexually Transmitted Infection Prevention at the Maryland Department of Health and Mental Hygiene. Ken is going to introduce today's speaker.
Thank you, Craig. It's great to see so many people in the audience. I know there's a lot of you out there, so stay tuned for a great webinar. On behalf of our Center of STI Prevention, the Maryland Department of Mental Health and Hygiene, and the Prevention and Training Center for Johns Hopkins and the Mid-Atlantic Regional Public Health Training Center, a lot of people, we want to welcome you to this webinar, our 8th Annual Sexual and Reproductive Health Webinar. Today's presenter, Dr. Jeanne Sheffield, who has joined Johns Hopkins faculty in 2015 as the Director of Maternal and Fetal Medicine Division, a professor in the Johns Hopkins Medicine Department of Gynecology and Obstetrics. She's a board certified in obstetrics and gynecology as well as maternal-fetal medicine. Her areas of clinical expertise include medical and surgical complications of pregnancy with a focus on infectious diseases and immunizations in pregnancy. Dr. Sheffield received her undergraduate degree from the University of Notre Dame and earned her medical degree from the University of Alabama at Birmingham. She did a residency in obstetrics and gynecology there, and then completed a maternal-fetal medicine fellowship at the University of Texas Southwestern Medical Center in Dallas, Texas. Dr. Sheffield serves on a number of national boards and committees and is a member of American College of Obstetrics and Gynecology, Alpha Omega Alpha, the American Gynecological and Obstetrics Society, the Society for Maternal-Fetal Medicine, and the Infectious Disease Society of Obstetrics and Gynecology, a mouthful. She also serves as pregnancy consultant for the Centers of Disease Control and Prevention. Finally, Dr. Sheffield has published numerous articles in obstetrics and maternal-fetal medicine journals and written a number of textbook chapters. She's currently an editor for Williams Obstetrics, the definitive obstetrics textbook used worldwide. She's a journal reviewer for a number of peer-reviewed journals in her specialty, and we welcome Dr. Jeanne Sheffield.
Thank you. Thank you very much for inviting me to come speak to you. It's a very interesting combination of topics. It takes something, we're going to start off with something that is very pertinent right now to worldwide, everybody's focusing on it, and then we're going to go to something that I think we should be focusing on more because it is on the rise in the United States and actually in several countries worldwide. So we'll start off with congenital Zika syndrome and where we're at, and then we'll go to congenital syphilis, something near and dear to my heart. I've been working on doing congenital syphilis research for about 18 years or so. So I have no financial disclosures. So let's start off with Zika. And I know you guys have been inundated with this over the last year, so I'm going to go through this part pretty quickly. I just wanted y'all to be aware of the history. This is not a new virus. This has actually been around since 1947 when it was first discovered in the Zika forest of Uganda. It kind of wandered its way into humans in the early 1950s, was the first human report, worked its way through Africa, worked its way into then Asia and Southeast Asia. But it wasn't until it spread to Micronesia in 2007 that we started seeing a true cluster of human cases. And then in 2013, 2014, it worked its way to French Polynesia. In French Polynesia, the outbreak was about 28,000 patients. And going back and looking at their data now, there was an increase in Guillain-Barré syndrome at that time. There was an increase in fetal abnormalities such as microcephaly, though none of these were actually identified or noticed at the time of the outbreak. It wasn't until it hit Brazil in mid-2015 and the report started coming out late 2015 of the fetal implications of Zika infection during pregnancy that it reached worldwide attention, that everybody suddenly started talking about this new virus, the Zika virus. So by September 2015, Brazil was reporting over a 20-fold increase in the number of microcephaly cases, and I'll talk about that in a second. So this was the big New England Journal report that came out summarizing those initial cases out of Brazil. So I always want to talk first about what is microcephaly, because that was the main thing that everybody was focusing on initially when we were trying to figure out how to identify this congenital Zika syndrome. And what microcephaly is just a small head in relation to the fetal sex and the gestational age. So a head at 26 weeks gestation and a head at 34 weeks gestation are going to be very different. So we have a nice algorithm. So we look at kind of where the head size falls in there. And it's been, we've known about microcephaly for decades, hundreds, centuries, because some babies are born with small heads, and there's a lot of etiologies for that. Genetic etiologies, infection, trauma, exposure, you name it. So there are a ton of different things that can cause microcephaly. This is one of the first viruses, however, that will cause almost purely neurologic diseases. Most of the sequelae from Zika center on the neurotropism of the virus itself, and we'll talk about that in a little bit. I always want to bring up one case report. This was one of the first cases that was reported in New England Journal of Medicine that got the worldwide attention. So this was a patient, a European woman actually down in South America, who had been working down there, was infected with Zika virus, and at about 13 weeks or so. Her ultrasounds at 14 weeks and at 20 weeks, looking at the baby, were absolutely normal. Unfortunately, when she went back to Europe, she was found to have a very abnormal ultrasound in the third trimester. And what it showed was a very small head, it showed growth restriction, less than the third percentile, and multiple abnormalities, including these intracranial calcifications that they talk about. And when you look at the pictures that they had in the New England Journal case report, these bright white areas are all the calcifications. And you can see it doesn't just center on one area, it's kind of all throughout the brain there. There were calcifications in the actual placenta on the ultrasounds. She was in Europe, ended up having a pregnancy termination, and on autopsy of this Zika-infected child, they found one very small kid at the 5th percentile. My whole brain microcephaly was at the 1st percentile with the brain weight less than 4 standard deviations. Very, very small, multiple calcifications. And when they did slices of the brain, what they found was they actually found the virus on the viral slices. I wanted to mention too, Zika doesn't just cause a small head, and a lot of reports have come out in the last few months on this. It doesn't just cause a small head, it causes marked brain abnormalities. And you'll notice here, most brains have the sulci and gyri, those kind of waves throughout here. You can see this brain is almost agyric, almost has no sulci and gyri here. And these are what we're finding on some of the Zika-infected infants. So it causes significant issues, not just with some calcifications in the brain or a small head. So right now, we now call it congenital Zika syndrome, which really is just a pattern of birth defects in fetuses and infants born to mothers that had Zika infection. And these are the pictures you guys keep seeing on the internet, the small heads, these cute little kids, but these kids have significant abnormalities. They have breathing disorders, they have feeding disorders, they're very agitated. There have been a number of deaths now resulting from congenital Zika syndrome infections. So where are we at right now in the United States? So this was the numbers as of this past week, and the CDC updates the numbers every week. So in the United States, as of last week, we have a total of 5,234 cases of Zika. The vast majority of them are travel associated, mainly travel down to the southern hemisphere and the islands, the U.S. territories. There are 223 cases locally transmitted in the United States. 6 of those are in Brownsville, Texas. The rest of them are in Florida. So right now, most of our focus has been down in those southern states. But as, it's starting to get into a warmer season now, we're worried we're going to start seeing more local cases here in the United States in other states besides just those two. In the U.S. territories, totally different picture. Instead of our 5,000 here in the states, the U.S. territories, we have almost 37,000 cases now. The vast majority of those are local, and a whole lot of those are down in Puerto Rico. In Maryland, since we always want to talk about congenital Zika in Maryland, right now what we have, fortunately, are no local cases, but we do have several travel-associated cases. We're actually one of the top 10 states for Zika infection and travel-associated cases. About 3% of the cases have been here in Maryland. Again, a lot more of them are down in Florida and such, New York. Virginia, since we do see a number of cases from them, a number of referrals, they have about 2% of the cases right now. So Maryland has a number of cases of maternal this is actually Zika for males and females. Fortunately, we have not had many congenital infections yet. So this is, one of the big questions is, if I am infected with Zika virus and I am pregnant, what is the chance my kid is going to have congenital Zika infection? So these numbers just came out. So this is as of March 28th. There right now are 5,177 laboratory evidence Zika infections in the U.S. 1,700 are in the U.S., 3,400 in the U.S. territories, 55% have had clinical symptoms, and this is the MMWR that came out a couple weeks ago, and it looks at all the cases in the United States of Zika infection from 12/1/2015 to the end of December 2016. So we had 1,297 pregnancies from 44 states at the time. During that time period, they had 972 completed pregnancies with reported outcomes, and this is what's happened. So these are kind of what's happened from March and April of last year. These are the number of pregnancies reported, so going up. Overall, 5% of the pregnant women that tested positive or had suspected Zika infection because of a combination of tests, their kids had congenital Zika syndrome, so about 5%. If they were symptomatic, it was 6%, asymptomatic 5%, so really symptoms probably don't matter as much as we thought initially they may. If you had first trimester exposure, however, that rate went up to 9% of babies. If they had true confirmation of Zika, so not just a combination that they suspected it or possible infection, if they had true confirmation of Zika virus infection, 15% of the babies exposed in that first trimester had congenital Zika syndrome. So we're getting more information now to help with our counseling for these babies. This is 30 times higher than we saw in the pre-Zika years. So even though we don't have huge numbers yet here in the United States, it is causing a significant burden, both statewide and nationally, a significant burden on the care of these infants, and we're going to see more of these infants. Part of the problem we still don't know is we still don't know what the effects are truly in pregnancy. Do pregnant women, are they more likely to get Zika virus? We don't think so. If they get it, are they worse? We don't think so. But the big question is, exactly how many pregnant women are going to transmit to their infant, and we're still working on that data. We have the preliminary stuff I just showed you, but we're still working on it. One of the important things, however, to notice is you do get transmission in all trimesters. So first, second, and third trimester, you're going to see transmission. It may be more common if you're infected in the first trimester, but there are a number of cases of women getting infected at 34, 35, 36 weeks of gestation, and their kid being born either with congenital Zika syndrome, with all those abnormalities that have been reported. Unfortunately, there are now cases that have been reported of infants born that are very normal appearing at birth, but if they have a CT or a head MRI, they are abnormal, or several months down the line, they develop symptoms consistent with congenital Zika syndrome, even though at birth they had no symptoms. So, I'm an OBGYN, so I always have to talk about all the stuff in the red there, which is my world as an OB-GYN. But the important thing to remember, and I should have bolded it, is the vast majority of transmission is through mosquitoes. So if you're going to do a big public health measure to try to prevent congenital Zika syndrome, you've got to prevent mosquito bites or prevent travel to areas of mosquito bites. So we talk about vertical transmission, and no question there are cases of vertical transmission, or there's cases of vertical transmission going from the mother to the baby. We talk about sexual transmission. We now know that the Zika virus can be transmitted either from a male to a female to a male, a female to a male. So multiple combinations. It can go back and forth, though it is more common to see it a male to a female than it is from a female to a male. And that's true with most sexually transmitted diseases. There are certainly possibilities with blood bank exposures. There's a couple, I think there's 3 or 4 cases now down in Brazil of blood bank transmission. Fortunately, we have not seen any here in the United States. The FDA jumped very quickly on the Zika virus, and all tissue and bloods are screened. So they've been very good about that. There is at least 1 case of laboratory exposure of Zika virus, so if you're working with it, there's a lot of precautions that have now been put in place. So this is where we're at with Zika right now. This is the distribution of that mosquito that carries it, the Aedes mosquito that carries it, and this is the exact distribution of where we're seeing Zika virus. And unfortunately, since I'm talking mainly to a big part to a Maryland population, you'll notice Maryland up here is right where both types of mosquitoes, unfortunately, that transmit the virus are here. So we are going to see these mosquitoes, and so there is certainly a potential to see local transmission. So how are we trying to prevent this? So there's a fair amount of data out there coming out of the CDC, the American College of OB-GYN, the Society of Maternal-Fetal Medicine, all these algorithms of how to try to prevent a pregnant woman from getting Zika virus. There's not a lot we can do once they get it to prevent transmission to the infant. So right now, most of our measures are on the preventative side. So for what we're doing right now is all pregnant women that travel to any affected area, there's beautiful algorithms in place. We test all pregnant women. There's also an algorithm, if you happen to live in an area that's endemic for Zika, there's a separate algorithm. They do the testing a little bit different. That's all available. There's infant and children guidelines for testing the infants. There's whole guidelines on the CDC website put together with the CDC and the American Academy of Pediatrics. They've just actually updated those in the last couple of weeks. And so there's a lot of information out there and guidance out there. There's telephone numbers you can call if you have questions. I wanted to put this in here. This was actually from Thomas Quinn. He's the director of the Center for Global Health here at Hopkins. And he showed me this, and I begged him to steal it because I think this is such a great slide. We're seeing so many different infectious diseases coming into the United States that we never used to. And it's because of globalization. Our world is globalized now. We don't think anything of jumping in an airplane and traveling down to the Caribbean for the weekend. Well, unfortunately, and this is travel, down to the Caribbean for the weekend type thing. This is down to South America. We think nothing about jumping on an airplane and traveling. Unfortunately, that's why we are now seeing, however, some infectious diseases that we never would have been experienced or exposed to before. So this travel has made our lives a little bit more interesting. So I wanted to mention testing just real briefly because this is a big part of the preventative steps. Testing for Zika is still not perfect. I was on the call with the CDC last week, and we were talking about testing. One of the women that sits has actually done almost all the work on congenital Zika syndrome was on the call, and we talked a lot about testing. And unfortunately, there's still a little bit of a ways to go. So the main thing we have now is PCR. PCR is wonderful. If you have the virus and the tests come back positive, it's great. The problem is if the tests come back negative, you don't know if they've just cleared the virus already or if they are a true negative. So a positive result for a PCR helps, a negative result doesn't. It's good for most people for about 7 to 14 days in the blood, up to about 14 days in the urine. For men, it may last in seminal fluid for several months, and so that's why the guidance is a little bit different for men than women on when they should conceive or when their couple should conceive. We also know, interestingly, in a pregnant woman whose baby is infected, the PCR may stay positive for weeks to months in the pregnant woman, where normally if she were not pregnant, it would clear within a week or two. So it may stay positive for months because of, the baby's infected, the placenta's infected, the mom, and it just gets this vicious circle. So the testing is a little bit different in pregnancy as to who you would send a PCR on. The other big thing, the thing most of us use as clinicians, of course, is the serologic testing. And for all the health departments on there, I know you guys have been inundated with this. I'm sorry, over the last year and a half, I think probably your whole life has turned into Zika testing and phone calls from us as clinicians to try to get approval for Zika testing. But this is kind of where we're at right now, unfortunately. So We have an IgM. IgM is the immunoglobulin looking for acute infection. We have an IgM. If it's positive, unfortunately, there are a fair number of false positives. If you've had dengue before, or if you've had certain vaccinations, it may end up turning it positive. So the health department will be asking you a bunch of questions about, have they traveled before? Have they had dengue before? What vaccinations have they had before? They'll be asking all that. If an IgM comes back positive, because of the high false positive rate, they send the blood then to the CDC. The CDC will repeat the IgM with a little bit different of an IgM test, and they will also do this PRNT test. And that's kind of an amalgamation of IgG, IgA. It's a good test to try to determine, if the antibody, if that IgM is positive, is it truly positive from Zika, or could it be positive from dengue or chikungunya or something else? So you'll get a PRNT report back from them, then the CDC, in 3 or 4 weeks, kind of giving you a better indicator of whether they're actually infected. The important thing for everybody, for all the clinicians out there, is there still is no approved IgG. So clinicians, we love IgG because it means they've had it at some point in the past. It turns positive, it stays positive for a while, it stays positive for years usually. And it's an incredibly helpful test for those patients that come in and said, I traveled to Brazil 8 months ago, I want to get pregnant, can you tell me if I've had Zika? And right now the answer is, I can't, because there is no IgG test. There is a lot of efforts being put into producing this test, but unfortunately we're still not there yet. So where are we at right now for recommendations for pregnant women? The CDC recommends that all women that are pregnant or even considering becoming pregnant not travel to areas with epidemic Zika right now. So if you have active Zika infection, ongoing Zika infections, don't travel to those areas. That's the first recommendation. It's the most logical one. That being said, a whole lot of people have to travel or want to travel to those areas. And so the next thing is, if you are going to travel to those areas, make sure you try to prevent the mosquito bite, because that is the big reason, or the big way it's transmitted. So try to prevent that mosquito bite. Use protective clothing. You can use permethrin infused in clothing if you like. Use US EPA registered insect repellent. So things like DEET are safe in pregnancy if used in the appropriate dosing. And there is a nice section on the CDC website as to DEET and permethrin and all these different insect repellents and safety in pregnancy, safety for children. So in EPA registered dosing, I am fine with using those in pregnancy. I actually tell people to avoid the non-EPA registered ones because we don't have any data about how effective they are. So use those. They're not 100%. These mosquitoes that transmit Zika are kind of bite all throughout the day. They're not dusk and dawn biters. They kind of bite all throughout the day. So make sure you're continuously putting it on in the dosing recommended. Stay in screened-in areas, stay in air-conditioned areas. Trying to tell my honeymooners that are going down to the Caribbean for their honeymoon to stay in screened-in areas and wear long-sleeve shirts, that's not going to happen. But at least I can tell them to use the insect repellent. There is a lot of guidance out there. This is some of the CDC guidance out there. There's guidance on the Maryland State Health Department websites. There is guidance on ACOG, American Academy of Pediatrics, SMFM, you name it. Everybody's got a bunch of guidance out there. Maryland was great about sending out Zika kits to prenatal clinics where each of my patients got 2 bottles of insect repellent and condoms and educational materials on how to prevent Zika infection. So Maryland as a state has been great about jumping on this and making available the resources that clinicians need, and the CDC has done the same thing. So I wanted to just spend about 20 minutes on Zika because I know everybody has been kind of inundated with Zika. Equally important, so I kindly got this slide from one of my colleagues here, and I love this slide. I'm now going to beg permission to use this for everything. Is we keep talking about Zika, and everything is Zika. And if a baby has a small head on an ultrasound, it is Zika. But it's not usually. You've got to actually remember all the other infectious diseases out there. There is syphilis, and there's gonorrhea, and there's chlamydia. So there's still big players out there. There's cytomegalovirus, which is actually transmitted sexually, and it's much more common to see perinatal infections from that. So there are other things. And of course, my favorite is going to be the little spirochete here, the syphilis. So I'm going to move on and talk for the next half an hour or so about congenital syphilis and where we're at here, or where we're at now. So syphilis I still have residents and medical students that have said they've never seen it, and syphilis is not a problem in the United States anymore. And I think what happens is, and George Wendell, who was my mentor and was considered, Mr. Syphilis in the United States, he was one of the big syphilologists is probably the right word, in the U.S. He is a firm believer in, when monies get put into something like Zika right now, rates go down. And when rates go down, suddenly monies are sent to somewhere else, like Ebola monies went to Zika. Suddenly the monies get transmitted to the next emergency and rates start going back up again. And then it's kind of this vicious cycle. So unfortunately, we're in the wrong part of the cycle. So this is back in the 1940s. Penicillin was developed mid-1940s. And you saw this beautiful drop in total syphilis. Syphilis, the bacteria, is exquisitely sensitive to penicillin. So it dropped beautifully. And then we had, unfortunately, kind of a bump here. A lot of the syphilis research in pregnancy came from that time period, that bump there. But it had to do with kind of cocaine epidemics, a fair amount of drugs and such in that time period. We saw a bump up, and then we went back down again. And people were like, okay, we're good. There was a big syphilis elimination money, the big push and everything. And as the money started, going to other things, unfortunately, in the last few years, we're starting to see a rise again in syphilis rates. And this is, I kind of blew it up a little bit. This is from 2006 to 2015. This is in reproductive age women. Since I'm talking about congenital syphilis, I have to talk about reproductive age women. So this is in reproductive age women. And this is, you'll see, pretty much across the board, in the last few years, we are seeing rates going up. This is like 25 to 29-year-olds, 20 to 24. We're seeing rates going up almost everywhere, except for the 15 to 19. It went up, and it's kind of, who knows what that means, that's just 1 year. But they're going up, no question, over the last few years. It's still a bigger player in men than women. And so I have to give the male side at least some credit here, because they still far more common in the men than the women, but you'll see that reproductive age group. I did want to mention, though, you do every once in a while see cases in the non-reproductive age group. And so you do have to remember that even in your older populations, you may see sexually transmitted diseases. That being said, I'm talking about congenital syphilis, so I'll stay with the reproductive age group. These are syphilis cases by state. And when I actually came from Dallas, we saw a fair amount of syphilis in Dallas. I was worried when I came to Maryland. I'm like, I've devoted my life to sexually transmitted diseases and syphilis and all that, and am I going to still see it in Maryland? Sure enough, I am still going to see it in Maryland. So we actually are, unfortunately, an incredibly high state. And I'll show you the Maryland data in a second, but this is kind of congenital syphilis rates that have happened in the United States from 2010 to 2015. It kind of mirrors what we're seeing, of course, in the primary and secondary syphilis rates in reproductive age women. So I'll show you the Maryland data in a second, but the big question has been, why is congenital syphilis, since that's what I'm here talking about, why is it on the rise? So we have seen a 36% increase from 2011 to 2015. Huge issue. 56% increase in primary and secondary syphilis rates during that same time period. So more of my reproductive age women are getting it, so they're more likely to transmit to or the numbers, just more likely to see higher numbers in the congenital syphilis rate. So we have to tackle maternal syphilis. When they looked at the 2014 numbers, so a couple of years ago, they looked at the 2014 numbers, 22% of the cases had no prenatal care. And that's pretty consistent with what we saw in Maryland, which I'll show you in a minute. So 22% of the cases in the United States in that year had no prenatal care. But if they did have prenatal care, 43% of them did not receive treatment. They either weren't tested or they seroconverted at some point after they were tested at the first prenatal visit and never got retested. Interestingly, some of them actually were treated, but they were treated in that less than 30 days. So they still counted as a congenital syphilis case because they didn't get treated and then waited 30 days. So there are definitely areas that we can improve on to try to decrease congenital syphilis rates. These missed opportunities are scary. The ones that even got prenatal care that still either didn't get tested, or if they came back positive, the provider would say, I think that was probably a false positive. I'll just retest her after delivery, which is the last thing you should be doing when you're talking about a pregnant woman, because this bacteria is devastating to a developing fetus. So this is congenital syphilis rates in Maryland. So this is where I felt better that I will still see some syphilis. I did not feel better that it was so high. So the blue line is all the Maryland counties. The red is Baltimore City alone. And you can see the numbers, just Baltimore City alone, are pretty consistent. So we see a whole lot of syphilis in Baltimore City. So this is 2014, 2015, overall rates are going up. This is some great data that the health department they gave me, and this is fantastic. So these are from 2006 to 2015. They had 206 congenital syphilis cases. When they narrowed it down, about 80% of the people got prenatal care. So all the cases were not in the no prenatal care group. There were some cases that were in the prenatal care group. And you can't read these numbers, but that's inadequately treated at 33, untreated at 30, I think it's 30, let me read it here, 38. Yes, I can't see it, 38. So these are the missed opportunities. These are patients in our own state that got prenatal care and either did not get tested or got tested and did not get adequately treated. And so we have some significant missed opportunities in our state alone. So I think we'll tackle this one. One of the reasons we've got to tackle it is we are the third highest state in the country for congenital reported syphilis cases. So this is reported cases and rates of reported cases by state. This is in 2015. You'll notice our rate is 25 per 100,000 live births. The only two states higher than us are California at 28.5 and Louisiana at 83.9. So significantly higher here. And when you actually look at all STIs at Maryland, ranked by state for several of the different STIs, in 2015, Maryland ranked 10th overall for primary and secondary syphilis. They ranked 3rd for congenital syphilis. They ranked 24th and 23rd for chlamydia and gonorrhea. So we're doing a little bit better. But this is the big problem. So we've got, and the title of the talk, so this is where we have to focus our resources right now. So what is congenital syphilis? It is a bacteria, or it happens when the bacteria crosses the placenta, so the mom has it. The mom, it goes disseminated, so it's going all throughout her system. It gets to the placenta gets infected, it goes to the kid, goes to the fetus. So at any gestation, unfortunately. So it can occur at any stage of syphilis and in any trimester. So it can occur at primary syphilis or secondary, as I'll show you in a minute, and it can occur across any trimester and cause issues. You may not have evidence of congenital syphilis at birth. So the pediatricians need to be aware that the mom tested positive and make sure that baby is evaluated and treated if need be, because they may not have symptoms initially. I want to talk initially about the diagnosis because it's surprisingly difficult. Again, I've spent many years, and one of my colleagues from the neonatology side, he spent his entire life trying to work on the diagnostics of syphilis, and it is incredibly difficult. So all infants that are born to mothers with reactive syphilis serology need to be evaluated. Test the baby, a serum, not cord blood, test serum on the baby. That's relatively new. There is no IgM. So unlike Zika, which is IgM, this one there is no IgM. All we have are the couple of tests I'll talk about in a second, but all we have are these other tests, not an IgM, so we can't tell, okay, this kid is acutely infected. There's no good one out there. They're trying, but there's no great one out there available to all of us. So you have to do physical exam, and there are definite abnormalities you can see. The problem is oftentimes you don't. Make sure you examine the placenta and umbilical cord. If you've got gray hair like I do, you probably remember the dark field filters. The vast majority of my residents and med students have never even seen a dark field filter to look for syphilis. Testing. So if you're going to draw a tube of blood, so instead of what they used to do, which is swab the lesion, scrape the lesion, or take off amniotic fluid, or test the baby, looking at under that dark field microscopy filter, now we can just draw a couple of tubes of blood, or tube of blood. And you can do serology. I told you there's no IgM, but there are two types of antibody testing that can be done. There's the non-treponemal. That's the traditional RPR, VDRL trust out there. That it's not looking at antibodies against syphilis, it's looking at antibodies against things that syphilis damage produces, like some of the lipoidal antibodies or antigens. The treponemal antibodies, these are actually directed straight at the treponeme, the bacteria. And these are the TPPA, the MHATP, the FTA-ABS. There's also these rapid ones, the EIAs and the CIAs that are used now for reverse testing. So that's what's out there right now. And this is what happens in a syphilis infection. You know, they get infected within about a few days, they develop IgM. So if we had a good IgM test, we'd at least be able to tell more acute infection. And then this FTA-ABS goes up, the TPHA goes up. So these start going up later. These are all kind of the untreated VDRLs and RPRs. So you can see there's a little bit of a delay. And this delay is the reason why people are starting to change the way they're doing syphilis testing. So the traditional way, the way I train, the way most of us in the room trained, is a traditional testing. You do an RPR or a VDRL. It's a nice little qualitative test. You get your result back. They give you a nice titer. And if you treat somebody, you can watch that titer go down. And there's guidance for what's a effective treatment and what is not. But if that titer comes back positive, you still need to do that second test to confirm that it's positive. That's the traditional way of doing it. Get your RPR and then do a TPPA and just confirm it. Because the RPR, there are some false positives with the RPR. So you do your confirmation test. That's great. It actually is the way all of us trained. It works well. We love it. The problem is it is more expensive. So the less expensive way of doing it, and where a lot of states are now moving to, and Maryland is moving to, is reverse sequence testing. So in this case, you do kind of one of the EIA or CIAs, one of the treponemal tests. If it comes back positive, that may mean, these are antibodies to syphilis. They may have had it 20 years ago. So we just don't know when they had it. So then you have to do a second test looking at the RPR. And if the RPR is positive, they have syphilis. And it may be in the past if they stayed kind of seropositive or present, but they need to be evaluated for syphilis. If it is negative, in the setting of the screen positive, if this next test is negative, you actually have to go to a third test, which can be one of the other tests, not what you used up here. You go to one of the other ones. TPPA is one of the common ones. So it's a little bit different. What are the benefits and problems of each one? So the benefits of the traditional testing, it detects active infection because you're screening with an RPR. It has, unfortunately, high rates of false positives, especially in a low prevalence area. And you can miss very early infection. Those first few days, the RPR and the VDRL take a little bit longer to turn positive. So you may miss very early infection. Reverse sequence algorithm, which is much cheaper, no question. It actually detects the syphilis a little bit earlier, and it will pick up, of course, treated infection. But the problem is this screening test, the EIAs and the CIAs, are very nonspecific. So you're going to have a decent number of false positives. And so you're going to have to go down 2 tests or 3 tests. So unfortunately, a little bit more of an issue with the reverse testing, but the cost of it is so much less that a lot of places have moved to it. This is what we as clinicians have to look for, of course, when you're talking about diagnosing congenital syphilis, is the big edematous placenta. You can see it's kind of pale and very edematous. The baby, this is one of our congenital syphilis babies from Dallas. You can see the huge belly. They had a huge liver and spleen, a bunch of ascites. You can see it's a little dark, unfortunately, with the lighting, but you can see these cutaneous lesions here. This is a cross-section of the umbilical cord. There's a whole lot of edema there, a lot of fluid that builds up. And if you look at it under the microscope, there's a fair amount of inflammatory response. This is a fetogram. Pretty much any baby that's born that's stillborn should always have a fetogram done, looking for evidence of congenital syphilis. Congenital syphilis used to be one of the biggest players for stillbirth in the United States and still is worldwide. So you're looking for these bony changes. The end of a bone should be nice and smooth. This is that moth-eaten appearance at the end of the bone that you're looking at kind of over here. So this baby would have evidence of congenital syphilis. This is an autopsy specimen from that baby. You can see the humongous liver. Livers are big. Livers in babies are very big. It should not be that big. So I'm supposed to be talking about prevention. The only way to prevent congenital syphilis is to prevent the mom from getting infected, or testing the mom and finding it and treating her adequately. So I'll show you. This is all evidence of secondary syphilis. This is one of my ladies down in Dallas. She had these palm lesions. You can see the textbook palmar lesions here. You can see some of the mucosal changes that you can get with secondary syphilis. This is a chancre of primary syphilis there. So those are kind of the clinical finding or clinical things that we're looking for, though screening is probably the biggest way of going, is the best way of going. So in the United States, screen all pregnant women. So all pregnant women need to be screened, both at the first prenatal visit, but also in Maryland, make sure you screen again at 28 weeks gestation and again at delivery in high prevalence areas. So in this Baltimore City, you absolutely should be screening at the first prenatal visit at 28 weeks and again at delivery. In low prevalence areas, some of the other counties in Maryland, you may want to screen just at the first prenatal visit and then you have to screen again at 28 weeks. No baby should ever leave the hospital until you confirm the mother has had screening during the pregnancy. That will prevent you getting a kid out of the hospital, then the mom's testing at delivery comes back, it's positive, and you have to go somehow find that child. So no infant should be discharged without syphilis screening results back. And then, of course, anybody that has a stillbirth should end up getting screened also. I wanted to put this in here just to show you that these things can happen in any stage of syphilis. So this is data out of where I was. This was from 88 to 98 during that bump in syphilis rates in the country. Primary syphilis, about 23% of the women that had primary syphilis at delivery, so identified at delivery, she had a chancre, 23% of the kids had congenital syphilis. Most of those, this gray line here is congenital syphilis, the purple is stillbirth. Secondary syphilis, if the mom had secondary syphilis, so disseminated all throughout the body, the chance of that kid being infected with syphilis was 60%. Almost half of those were stillborn, half of them were live-born with congenital syphilis. But the other important thing to notice is even if they have no evidence of infection, clinically they have nothing. They're in that latent stage. They test positive, but they have no symptoms. You'll see transmission rates were still 36% if they were recently infected within the last year, or 7% if they were infected at some point in the distant past. We have no idea when. So no matter what stage of syphilis, you can transmit to the infant. The other important thing to know, though, is treatment of syphilis is incredibly effective. And so if you screen the mom at the appropriate time and you find syphilis, you can treat the mom and you'd be surprised at how well it works to treat the baby. So this is syphilis efficacy by stage. This is, if you have primary syphilis, it's 100% efficacious. Secondary, the first time you give a dose, 95%, and so on. So incredible. Penicillin works beautifully for syphilis. It also works wonderfully because it crosses the placenta and treats the infant at the same time. So I'm a huge believer in screening and treating, hopefully 30 days or more before, or more than 30 days before delivery, so the baby isn't automatically labeled as congenital syphilis. It also works well regardless of gestational age. Some people are worried because blood volumes increase so much in pregnancy that maybe in later gestation it's not going to work as well. It works well regardless of your gestational age. So the final message kind of going through all of this stuff with congenital syphilis and with Zika virus, also our congenital Zika syndrome, the final message really is your state and local health departments are there. They're your allies in this fight. When they pick up the phone and they call you and say, hey, you've got a positive, can you get them in? Could you tell me more about them? Whatever. Please answer the phone. Be polite. Do your best to give them as much information as possible because these are both of our patients. This is a public health, huge public health concern, but it's also my patient in clinic and I want the best thing for her and her baby. So when they call you, please answer the phone. Give them the information that they need. Don't hesitate, however, on the opposite side to call them. I frequently, if I have a patient that comes in and her syphilis testing is positive and her titer is like 1 to 2, so a low titer, I call up the health department and say, can you please tell me if she's ever been treated? Because half the time the patients say, yeah, I got a shot for something in the past, or I got a shot for an STD, which turns out to be Rocephin for gonorrhea, not penicillin for syphilis. So the health department can work that out. They can find out, if she said she got treated in Dallas, they can pick up the phone and call the Dallas Health Department, and vice versa. So they are also your allies to try to determine if your patient this time needs to be treated. They also will help you with contact notification. I already mentioned researching prior treatment, interpreting results. Some of these results, especially this reverse testing that the whole state is going to, can be difficult to interpret. So give them a call. They can help you also interpret the results. And I've already mentioned this one. The big thing though is just remember both syphilis and congenital Zika, these are reportable or notifiable diseases. You have to tell them. Now, a lot of times hospitals will work out, okay, if a test is positive, the lab will send it, but you also need to be responsible for making sure the health department is notified. This is kind of the morbidity report form for Maryland. It looks daunting. It's not that bad, I promise. I've actually used it now, and it's not that bad. And there are a ton of resources, not just picking up the phone and calling them, but there are also a lot of resources online. So most of us are walking around with our phones or our iPads, or plop down in our clinic with our desktop or laptop open. Pull up these websites for both Zika and for syphilis. So this happens to be the Maryland Department of Health and Mental Hygiene at maryland.gov. They have a bunch of information, plus they have links to the CDC and ACOG and MFM, so to try to make sure you get to the right spots. I already mentioned these, the CDC, I've already mentioned these, and you guys will have the slides, you'll be able to use these links. ACOG, American College of OB-GYN and the Society of Maternal-Fetal Medicine, we've been working very carefully with the CDC to make sure that all of us are developing the same guidelines. Same guidelines for Zika virus, which a lot of these things are on Zika, but there's also an STD section too. Though, frankly, the STD sections, I would use your health department for that. But there are plenty of toolkits out there and available for everywhere. And then the last thing I wanted to mention is the STD Clinical Consultation Network. So this is a network throughout the United States. It provides STD clinical consultation services. It's not immediate, but it's very quick, within 1 to 3 business days, depending on the urgency. And it goes to healthcare providers nationally. There are experts, there are experts in this and that. You call them up, you leave your message or you leave your information, your question, and they will get back to you. It's linked to the Regional STD HIV Prevention Training Center. The faculty that are involved there, they will call you back, and put the website down there just so you guys know how to get a hold of everybody. And with that, I'm going to finish. I finished a couple minutes late. I wanted to do 40 minutes. I did 43. But these are, if you guys have any questions, please email me the questions. If we don't get to them in this time period, I am also always glad to answer questions via email. So these guys can get a hold of me and send me the questions via email. Yes, ma'am. Got it. No problem.
A question about syphilis and a question about Zika.
Perfect.
So the question about syphilis is, if you can be infected at any point during gestation, does it make a difference when you treat in terms of the outcome of the pregnancy?
Yeah, that's actually a superb question. So most of the, if I had more time, I'd go into the timing stuff. So that's a great question. Thank you. So if a woman gets infected in that first 18 to 20 weeks, we actually don't usually see infected kids. Most of the problems we see from the infection is secondary to the inflammatory response to the bacteria, and that's usually after 18 to 20 weeks. So the earlier stuff, you may see a miscarriage or a fetal demise. The later stuff, the thickened placenta, the fluid around the baby, the big livers, we can see all of that with ultrasound. We usually see that after 18 to 20 weeks. All of that being said, if you treat at any time during the gestation, you absolutely will be almost 100%, nothing's ever 100%, but close to 100% effective in preventing congenital syphilis or treating it if the kid already shows evidence. The one caveat I'm going to throw out there is, for treating adults, you get this, some adults will get this Jerish-Herxheimer reaction. You treat them, they feel crappy for about 24 hours. The problem is if a kid is infected, so a fetus is infected, say a 25-week fetus, there's evidence of congenital syphilis. If you give the mom penicillin, it works great in crossing the placenta. The problem is the fetus can actually have a Jerish-Herxheimer reaction. And we've seen fetal monitoring where the heart rate starts going down. There have been reports of stillbirths from it. So in patients that I'm treating later on in gestation, it still works beautifully, but if I do an ultrasound before I treat them, if the ultrasound shows evidence of congenital syphilis, I actually will treat them on labor and delivery on the monitor and see what this kid's doing, because the kid may have effects. But the earlier on, the better, to give it, the more time, the better. But even, they could be 5 minutes from delivery. Well, okay, I wouldn't do it then. But, up to about 30 days before delivery, if you go beyond 30 days, you should have adequate treatment.
Great, thank you. And then my Zika question is, early on when they had the reports of microcephaly, it seemed to be very regional, or the incidence was regional, and so there was a question of whether there was a cofactor or co-infection that was contributing to the increased rates of microcephaly. And I was wondering, a year out, has that sort of resolved, or is it still at the
So
early?
that's one of the hot questions that we always ask about the Zika questions. And our audience can hear her question, correct, from the microphone? So, okay, good. I just want to make sure that everybody could hear it, even those that are listening in. So, confounding factors. So why did Brazil see especially certain areas in Brazil, see such a huge increase in microcephaly and the congenital Zika syndrome where other areas didn't? And why did Colombia start reporting cases so much later? Puerto Rico reporting cases later? Some of it is timing. Some of it truly is timing, as it comes in, it takes months before you're going to start seeing a congenital Zika effect. So some of the later delays in the Colombia and Puerto Rico are purely timing stuff. But the other big question, and the unanswered question still, though some data is coming in, is such as prior flavivirus infections. Does a prior dengue infection provide some protection, or on the contralateral side, does it actually make it worse? We know if you've had certain prior infections and you vaccinate somebody, they may actually have a bad reaction to it, or not respond, or respond differently if they've had another one of the similar diseases. So we still, believe it or not, don't know that. We're getting more information about some mutational changes, though there really is only one serotype. We're getting some certainly mutational change questions, but we don't, on this co-founder or the confounding factors, we just don't know yet. We can't say for sure, but that's a great question because everybody keeps asking that. Did you have a question also?
Yes, thanks, Jeanne. So my question's about congenital syphilis, and I'm wondering for the Maryland cases, it's a lot and we shouldn't have them, but it seems to me that there are, relatively speaking, still so few that one could go back and review charts and say, where's the failure? Is this failure to diagnose? Is it failure to treat? Is it that they were treated, but it was within less than 30 days to
So
guide
I think some
policy?
of that, I think Carl has actually provided some of that in that slide, and they have been looking at it. So I have now met some amazing people in this group, and they have been looking at it. And unfortunately, of those 206 or so that are out there, unfortunately, a number of them, the moms got prenatal care, they were diagnosed, they were either inadequately treated. Some of them, when you start looking at the cases, some of them the moms received Pen-G instead of Bicillin, which have very different pharmacokinetics. Some of them got their one course, but they never completed. Or, they did it, and then 3 weeks later, they may have got another one, and they're supposed to restart, and, so they got inadequately treated. And some of them, it was just the providers did not realize that a positive test, they either didn't notice a positive test, in the world of electronic medical records, you don't have that sheet in front of you, you got the screen, unless you go to the right screen. They may just not have seen the positive RPR, or if they saw it, they just didn't know if they should treat it or not. So, but they very much, they have been looking at those 200 and some cases. Yes, sir.
Just a quick question about risk-benefit ratio of treating congenital syphilis among women who have indeterminate results of your testings.
So that has been brought up. We haven't had that many problems with the traditional testing. And so life was kind of good. We did the traditional testing. We didn't have that many indeterminate type things. The big question is, what do we do with this reverse testing algorithm, the reverse sequence algorithm? And there is some data. Ina Parks did one great study looking at pregnant women in the California system. And what she found was those that had the CIAs or the EIAs positive, more than 50% of them ended up being false positives. So there is a cost benefit. Penicillin is cheap. Bicillin, cheap as dirt. I'd love to give everybody penicillin. I firmly believe everybody should get Rocephin, penicillin, and maybe some zithromycin just for the benefit or for the sake. But there are consequences of just treating everybody. My antibiotic stewardship hat has an issue with it. The penicillin isn't usually a huge issue. So this reverse algorithm, there are now some cost-benefit analyses that are coming out. I know of 2 so far of the reverse testing, and and treating in pregnancy, and what do you do for those indeterminates where it's positive but the RPR is negative, and then you have to go to the TPPA, and by this time you're 3 months down the line, and should you have just treated them? I've seen 2 abstracts already looking at that, and one of them showed a cost benefit of just treating everybody. One of them did not. So I don't think there is a right answer out there yet, but I think with this reverse testing rolling out to so many places now, that is going to come. I mean, we're going to have to start talking about it. My antibiotic stewardship hat is not a huge fan of it, but you know how that goes. Any other questions I can answer?
I have a question about mosquito season. Those of us in the Mid-Atlantic region are going to be heading into mosquito season soon, if we're not already there, despite today's cold weather. Is there any sense yet of how big a problem Zika will be given our prevalence of mosquitoes in this general Mid-Atlantic area?
So I think there's a couple of things. United States, just in general, United States, pretty much they have said be prepared. So we're hoping what the NIH and the CDC are hoping for is 2 to 3 years, into this, it'll die out, or it'll go to endemic levels, which we see a lot in Southeast Asia and Africa. So we're hoping, as it kind of rolls through 2 to 3 years, or just entering into the first big summer. It didn't reach Florida until, summer of last year. So we're just entering the first big center where the whole United States potentially is at risk. So the word for the whole U.S. is be prepared. Continue your screening. Do your insect repellent, et cetera. Interestingly, Maryland and our surrounding areas are found to have one of the longest mosquito seasons, which I had no idea until I heard this just a few weeks ago. We actually have one of the longest mosquito seasons. So we absolutely have to be prepared. One of the concerns is, and I believe in global warming, so I just put that out there. I am a believer, and I think that is playing a factor also in these extended mosquito seasons we're seeing in multiple states, not just Maryland, but Maryland actually has a very long mosquito season. So I think Maryland healthcare providers need to be prepared for both testing and for possible evaluation and treatment of these infants. All right, if y'all have, oh yes ma'am.
We have an online question that came in. Can you speak to the problem with U.S. availability of long-acting benzathine penicillin? We continue to hear that there's a shortage, though fortunately our clinic has a good supply, and that is someone from Rochester, New York.
So that is actually, so I've lived through the last big shortage. So, kind of same thing. Benzathine penicillin kind of goes up and down in supply and availability. It's not a big moneymaker. So, not everybody jumps on and says, oh, okay, this is a cholesterol medication and I'll make millions. It's actually a very inexpensive, it's out there. But availability does wax and wane. So the last big time that it waxed back or waned when I was in Dallas, we worked with the state health department and got the doses available to make sure there were always enough doses available for pregnant women. We did this last year when we got a notification in Maryland that there may be a benzathine penicillin shortage. We went to Hopkins and said, being at Hopkins, we went to Hopkins and said, there's a potential shortage coming up. And we made a protocol in place where benzathine penicillin was saved for pregnant women. And they could use, if in the case of a shortage, it would only be used for pregnant women. And the health departments that were good have been good about sharing benzathine doses in times of shortage in various states. So there are mechanisms in place for either sharing benzathine penicillin doses or making sure that those doses that are there are saved for pregnant women. So I'm a big believer in that one. The other big question is, and actually that you may be getting to this, is what else is there if you don't have benzathine? And the problem is the best medication that treats the mom, crosses the placenta, and treats the baby is penicillin. There is no other agent out there that works as well. We don't use doxycycline in pregnancy. Erythromycin showed about a 10% failure rate. And a failure for syphilis is a congenitally infected kid with a huge risk of either stillbirth or long-term demise. So failures are not acceptable. So penicillin remains the main drug. There isn't anything else right now that works perfectly. They are looking at azithromycin, like a couple of grams of azithromycin may be a player, but right now penicillin is the big thing. And with that, I think we are done with questions. Thank you all very much for your attention.